I'd like to first introduce Kim Persley. I trained with Kim at Southwestern, right on the other side of town. We were both in training at Parkland together. She was chief resident right after I left, along with Tad Tullison, right? You and Tad were chief residents together, and she ended up doing her fellowship here at UT Southwestern, spent a year in Mount Sinai doing an inflammatory bowel disease fellowship, and she's going to give us her first lecture about inflammatory bowel disease. Kim, thank you.
All right. Good afternoon, everyone, and thank you guys for inviting me to come and have this discussion. So I've been charged with reviewing current state of therapy for inflammatory bowel disease. Now, this could be a big topic, but what I ended up doing, I had a conversation with my colleagues at work, and we were talking about, are there some common themes that we are seeing as gastroenterologists as it relates to treating our patients with inflammatory bowel disease. And then I also had a discussion with some of my patients and asked them, are there questions that you guys have about how we go about doing what we do? And so that's kind of how I structured my talk. So today, what I'm going to do is that we're going to talk about a few cases. We're going to do the IBD basics. We're going to talk about therapy. And of course, I have a slide on COVID and IBD. So here are just 4 patients that I saw 1 week, about a week or so before my slides were due. So the first patient is a 21-year-old woman, college student from Honduras with moderate to severe Crohn's ileocolitis, diagnosed after a recent hospitalization. Second patient is a 47-year-old woman with moderate to severe ulcerative colitis after presenting with a 3-month history of diarrhea and weight loss. She has diabetes and hypertension. Third patient, a 28-year-old woman with moderate to severe ulcerative colitis, and during the pandemic, lost her health insurance, stopped her adalimumab, was doing great, then flared up, was able to get samples of Xeljanz, did not respond, and was hospitalized with a flare-up, and also diagnosed with COVID. And the fourth patient is a 52-year-old woman with Crohn's colitis in remission. She had a recent colonoscopy, histologic normalization, and her question is, I really want to stop taking this medication. It's too expensive, and I'm afraid of getting COVID, but doesn't want to get vaccinated. So inflammatory bowel disease is a chronic idiopathic inflammatory condition of the GI tract. In 2021, the cause is still unknown, and there's no known cure. The disease is characterized by relapses and remissions. Although there is no cure, we have a number of effective therapies to treat the inflammation related to inflammatory bowel disease. When I think about inflammatory bowel disease, and what I tell my patients is basically there are 2 types. We have Crohn's disease and ulcerative colitis. In Crohn's disease, you can have inflammation anywhere from the mouth down to the anus. The inflammation is patchy, so you can have an area that's normal next to an area that's quite diseased. The inflammation is transmural. So because it's transmural inflammation, patients can develop complications such as fistulas, abscesses, and strictures. Patients will often ask, well, why can't you just cut it out? Well, we reserve surgery in Crohn's disease for complications. Surgery is not a cure, and even after surgery, patients will need to be on medications to prevent their disease from returning. In contrast, ulcerative colitis, the inflammation is limited to the colon. Varying extents of the colon can be involved. The patient may have disease limited to the rectum, left side, or the entire colon can be involved. The inflammation is superficial or confined to the mucosa, and for that reason, we don't see the complications with fistulas and strictures. Surgery is curative, but we tell our patients, even if you have just rectal involvement, if you have surgery, you're losing your whole colon. Some patients, or most patients, are eligible to receive a J pouch, and continuity can be restored. So when I'm seeing a patient with inflammatory bowel disease, there are several questions that are going through my mind when I'm seeing the patient. First, am I seeing the right patient? Does this patient have inflammatory bowel disease? Still surprises me the number of patients that I will see who are being referred for IBD, but what do they really have? Well, they were hospitalized with ischemic colitis or infectious enterocolitis, or maybe it's irritable bowel syndrome. So I want to make sure that I have the right patient, and I believe the diagnosis of Crohn's or colitis. What about the right medication? When I think about right medication, what that makes me think of, how sick is my patient, right? So the level of sickness will help me to determine what's going to be the best medical therapy for that patient. What about the timing? Where is this patient in their stage of life? The way that I treat a 24-year-old woman who's thinking about starting a family is going to be different than how I'm going to treat a 65-year-old man. They may have the same disease activity, the same disease severity, but the approach is going to be different. And what is my target? What am I trying to achieve in this patient? And I think having this kind of open discussion with the patient as I'm sitting across from them helps them to understand kind of the method behind the madness of why I may be choosing one drug versus another medication to treat their disease. So I think it's important for us to make the distinction between disease activity and disease severity. So activity, when I'm looking at a patient at the time of the consultation, I'm assessing what is their disease activity. What are they like at the time of that consultation? For years, we use activity indices like the Crohn's Disease Activity Index score, which is a tool that uses 8 different parameters. You come up with a weighted score. A score of less than 150 is clinical remission. And the trials that look at patients with moderate to severe disease, Crohn's Disease Activity Index was usually between 220 and 400, and a response would be if someone had a drop, a reduction of 70 to 100 points in their Crohn's Disease Activity Index score. But this is cumbersome. Patients have to do a diary for 7 days, and most patients, when they would be in the waiting area just filling out their diary right before their visit. Something a little bit simpler is the Harvey-Bradshaw Index, and for UC, we also have the UC Mayo score that uses not only clinical symptoms, but also looks at endoscopic involvement. When I think about severity, though, severity is more about prognosis, right? So we can see someone at the time of the consultation, their symptoms may not be that impressive, but when we look at where the disease is located, what it looks like endoscopically, we look at their symptoms, how it's having an impact on their quality of life, their age, those things help us to determine the severity of their disease. This was a study that was published a few years ago, and what I like about this study is that the authors wanted to look at defining disease severity, and so they looked at 3 different domains. The domains were the inflammatory burden that the patients had, the impact on the patient, and then what complications the patient had of their disease. So like inflammatory burden would be how much of the bowel is involved, CRP, other inflammatory markers. And what we know when we look at defining disease severity in this fashion, we'll see that some people may have a significant inflammatory burden. They can have inflammatory changes throughout their small bowel, but not have much in the way of symptoms, but they have severe disease. Or we can see patients who may not have a whole lot of inflammation, but they have fibrostenotic changes in their ileum, and they're quite symptomatic. They're losing weight. It's having a huge impact on their quality of life. So really, we not only need to look at activity, but severity when we're trying to select what is the best therapy for the patient sitting in front of us. So years ago, when we would go to meetings, there would always be these kind of controversies in IBD. And one of the controversies was, should we be doing a step-up approach or a top-down approach? Truth of the matter is, most of us use some kind of combination. But with the step-up approach, what did that look like? Well, with step-up, we would start patients on therapy, 5 ASAs and antibiotics. And if they fail those therapies, then move up to more highly effective therapies and reserve biologics until the very end. The rationale for this was that we could possibly avoid exposing some of our patients to these drugs that had more potentially serious side effects. The top-down approach said, no, we really should be starting these highly effective drugs early on, and that way we can actually have a huge impact on the quality of life in our patients, prevent them or reduce the need for steroids, reduce the need for hospitalization and surgery. I really think that this whole step up versus top down was kind of artificial because, like I said, most of us knew that there were a group of folks, when you saw them, you know that you needed to get them on a biologic sooner than later. So what we have now, I think, is the whole idea of treat to target. This is the STRIDE 2. This is from STRIDE 2. And STRIDE, what this is a group of IBD docs who have looked at the literature and looked at different treatment targets. They've done surveys and come up with a consensus about targets that we should be striving for when we're treating our patients with inflammatory bowel disease. There are short-term targets, intermediate targets, and long-term targets. So in the short term, when we're treating our patients with inflammatory bowel disease, first and foremost, we want them to feel better. We want to hopefully get them into remission. And we also, long-term targets include seeing improvements at the endoscopic level. There were some other targets considered, but they're not formal targets in STRIDE, and that includes in Crohn's disease, transmural healing, and histologic healing, and ulcerative colitis. There just wasn't enough data to make this as a part of the target algorithm. This actually makes sense. And I think when we talk to our patients, because patients want to feel good, and, sometimes it's a struggle to convince them that, we're changing therapy, they're feeling better. But when we've done their scope, and particularly in our patients with Crohn's disease, where we know that there's a disconnect in what we see endoscopically and sometimes what they're reporting, why are we making a change if I'm feeling better? Well, again, that's one of our long-term targets. Now, when I say we want to improve the endoscopic appearance, I am not going to change a therapy if I see just a few little apathy here and there in the colon or the ileum. But I think we've all seen those patients where we stick the scope in, patients are feeling better, their CRPs aren't elevated, and it's really surprising to see the degree of inflammation. So this is how this information helps us. So on this slide, I've just listed what are some of the IBD medications and their indications. So when I was in a fellowship, we had 5 ASAs, antibiotics, purine metabolites. Very few of us were using methotrexate. And Infliximab was approved during the end part of my fellowship training. And since that time, there have been a number of other biologics, anti-TNFs, anti-integrins like vedolizumab, and these new smaller molecules like Tofacitinib and ozanimod. So we have lots of options, lots of tools in our toolbox right now that we can look to try to improve inflammation in our patients. Also, I want to draw your attention, there are a number of resources out there to help us with coming up with the right therapy for the right patient. Our societies have guidelines, technical reviews, clinical care pathways, and clinical decision apps that help to guide us. And when you first look at some of these clinical care pathways or reviews and guidelines, it can look quite confusing. But when you go through them, they really have made remarkable changes to simplify them. So use these resources to make sure that you are providing the best care for your patients. These are just some resources. The first guideline is from the ACG. The American Gastroenterology Association has guidelines. For my patients, I like to refer them to the Crohn's and Colitis Foundation. I think they actually break down the information a little bit better for patient use. And then for patients who are pregnant, I've referred them to the IBD Parenthood Project. So there are lots of resources out there to help us get our patients on track. So when I was talking to my partners, these are some of the questions that came up. First, is there a role for azathioprine, 6-MP, and methotrexate in 2021? How do we position these new molecules, these small molecules that have been approved for ulcerative colitis? And is there a role of combination therapy, in specific combination therapy with combinations of biologics? With our patients, there were a few other questions that came up that I'll address in a little bit. So what about the purine metabolites? azathioprine, 6-mercaptopurine. These drugs have been around for a long time, and the early clinical investigator-driven trials came out in the 80s, and these trials showed that AZA 6 and P were effective therapies at maintaining remission in our patients with Crohn's disease and ulcerative colitis. In the last few years, I've started a handful of patients on AZA and 6 and P. I think really where AZA and 6 and P play a role in my practice is combining them with other therapies, specifically biologics. The two trials that I want you just to be aware of, Sonic and Success. The Sonic trial was the trial that looked at combination therapy with purine metabolites and anti-TNFs. And the takeaway is that when you combine the two, they work better than monotherapy. With the Success trial, the same concept, using these in combination with an anti-TNF for our patients with ulcerative colitis. Again, there were improvements in quality of life scores in the group of patients who received the combination therapy. Do I start everyone on combo? No, I'll start many of my patients on monotherapy anti-TNF, but if they lose the response over time and I have to start a second anti-TNF, I will do combination therapy. Methotrexate. So the early studies with methotrexate came out in the 90s for Crohn's disease. Dr. Brian Fagans showed us that once a week injection of methotrexate, 25 milligrams, better than placebo at treating active disease and maintaining that remission at a 15 milligram weekly dose. There was always some back and forth about whether or not methotrexate was effective in ulcerative colitis patients. And in the trials that looked at methotrexate in ulcerative colitis, although there was a trend for improvement, it didn't meet statistical significance. And I don't use methotrexate in my UC population. When they looked at methotrexate in combination with anti-TNFs, again, are we going to see the same stuff that we saw in Sonic? We did not. In the COMMIT trial, methotrexate in combination with infliximab was no more effective than infliximab alone in our patients with Crohn's disease. What about the new small molecules? The two that I want to bring your attention to, Tofacitinib, which is a JAK inhibitor. It was approved by the FDA for treatment of moderate to severe colitis, ulcerative colitis, in patients who had failed an anti-TNF. What's nice about it, it went from a BID dosing to a once-a-day dosing. It has a novel mechanism of action. It's oral, so patients like it. You do have to monitor CBC, liver function, and check lipids after starting it. There are some safety concerns with the risk of blood clots. I didn't put zoster on here. This is not a drug that I'm comfortable using in my young female patients who are wanting to start a family. I just think we need more data. The one thing I will tell you is that what I have noticed is that patients who respond to Tofa, if they're going to respond, they usually respond pretty quickly. And once they respond, they've actually had a durable response to the medication. The sphingosine 1-phosphate receptor modulators, ozanimod, this is the newest one that was just recently FDA approved for ulcerative colitis. Again, once daily dosing, novel mechanism. Things to bring your attention to, if you have patients who have a cardiac history, you definitely need to get an EKG. If they have some type of arrhythmia, they should be seen and evaluated by cardiology. There's some ophthalmologic there's some eye issues that need to be followed up. And if you have someone with an eye issue, they should see an eye specialist. Varicella, if someone has not had a history of chickenpox or they do not have varicella antibodies, they should be vaccinated prior to. I have not had an opportunity to use this medication yet. When I've had conversations with patients regarding this therapy, they've been a little hesitant because I think of the newness of it, but I am, I'd like to use this sooner than later. It looks very promising. So patients ask often, so why do we choose one drug over another when you're having this talk with your patients about biologics? Why are you doing this biologic versus the other biologic? And what I tell my patients that, we have very few head-to-head trials looking at one biologic versus the other, but I want to bring your attention to two head-to-heads. The Varsity study, which was published a couple years ago, this was a double-blind, double-dummy randomized control trial looking at vedolizumab versus adalimumab in patients with moderate to severe UC. 80% of the patients were bio-naive. What they found in the study was that vedo was slightly superior to adalimumab when it came to endoscopic healing and clinical remission. Steroid-free clinical remission was slightly higher in the adalimumab-treated patients. I think this is interesting, but the study that I wanted to see was a head-to-head between vedo and infliximab, because I think for many of us, if we have a patient with moderate to severe UC, we're probably going to do infliximab before we do adalimumab. The other head-to-head is one that I think is still only in abstract form. This was presented at this past DDW, ustekinumab versus adalimumab. These were moderate to severe Crohn's patients. They were bio-naive, and the primary clinical endpoint was remission at week 52. Now, this was designed as a superiority study, and what the results showed is that the rates of remission, steroid-free remission, and clinical response were the same in the ustekinumab group versus the adalimumab group. I think the way that this is helpful for me, particularly when I'm having a conversation with my patients, adalimumab has been around for a long time. People know this drug. They're familiar. They're comfortable with this drug. However, I think it's helpful to say, hey, with ustekinumab, the dosing is different, right? If it works, you are getting an injection every 8 weeks, which I think is very encouraging for a number of our patients. So what about combining these biologics? There were a number of abstracts presented at this past DDW. This is just a paper that was published that I want to just bring your attention to, and this was out of Mayo, small study, only 15 patients, and they looked at combining different biologics, vedo and an anti-TNF, ustekinumab, and ustekinumab and vedo. I have a number of patients that I have inherited from Dr. Bincy Abraham, and they are on ustekinumab and vedo, and I was always a little bit concerned, are they at increased risk of infection? And with this study, what it did show is that clinical response was seen in 4 out of 5 patients, and there weren't any increased risk of infections in this study. So as far as the therapy question, is there a role for AZA, 6-MP, and methotrexate in 2021? Yes. I think combining AZA, 6-MP with biologics better than monotherapy, and we get that from SONIC and Success. AZA, 6-MP, and methotrexate are effective at maintenance of remission in Crohn's disease, and we did not see that statistical benefit in UC. AZA, 6-MP are effective at maintaining remission in UC. How do we position these new molecules? Well, the use of TOFA in moderate to severe UC patients after TNF failures, those patients have done really well with this combination. Using ozanimide in moderate to severe UC, but you want to make sure that you check cardiac history, if they have cardiac disease, and also if there are eye issues. Combining biologics may be helpful in folks who have severe disease. However, coverage is going to be a challenge. It is sometimes easier if the patient has a second diagnosis, and I've worked with my derm and rheumatology folks to sometimes get that second therapy approved by insurance. COVID and IBD, we are telling our patients that vaccinations are safe. The immune response may be blunted, and for those folks who've gotten the Pfizer vaccine, they should get that third. I'm not de-escalating therapy during the time of COVID. Really, the only thing I'm trying to do is get people off of steroids, but if they're stable and doing well, I don't think that this is quite the right time to start decreasing their infliximab dosing or trying to stretch out intervals. I'm just going to ride what we got going on until we're on the other side of the pandemic. So goals of therapy: do I have the right patient, the right therapy, the right time, and have identified the right target? Going back to our cases, so the first patient, the 21-year-old who had moderate to severe Crohn's ileocolitis, she was started on Humira, had an amazing response, did well. For the summer, went back down to Honduras, had a flare-up. She tested negative for C. diff, came back to the States. We checked her drug levels. She had no detectable drug and lots of antibodies against adalimumab. So for this patient, we're now putting her on infliximab with AZA. The second patient, the 47-year-old woman with moderate to severe ulcerative colitis after 3 months of diarrhea and weight loss. She's diabetic, hypertension. She had no known heart disease. She elected to kind of go old school and did steroids with oral and topical 5-ASAs, doing well. We talked about some of the newer agents, and she wanted to try what has been tried in the past. And if this is someone, if I were going to put her on ozanimod, I would definitely want her to be cleared by cardiology because of her diabetes, hypertension, and we're not sure about her cardiac history. The third patient who had moderate to severe disease and lost her insurance, she was hospitalized, was discharged on oral prednisone, and will be insured in a few weeks. And the goal is to get her back on, we're staying within class and adding an immunomodulator. And then the last patient who had Crohn's colitis had a normalization of her colonoscopy, did not want to stay on her medicine due to concerns about COVID. She's staying on her medication. And again, I continue to encourage her every time we speak, have you gotten your vaccine yet? Have you gotten your vaccine? So with that, I want to thank you guys for inviting me to speak today. And I look forward to the rest of the session. Thanks.
Thank you, Kim. And Kim will be available at the Q&A session to take questions. I'd like to present our next speaker, Kim Isaacs. She's from University of North Carolina, where their barbecue competes with ours with the vinegar sauce. And she's also shares the commonality with Kim personally. She was chief resident at UNC before training there and becoming faculty. So grateful for you coming to Texas and giving us this talk today.
Well, we definitely know that vinegar barbecue is better than. No, I'm sorry. So I want to thank you for inviting me to come and speak. And I think what I have to say actually adds very well to what Kim just spoke about. What we're going to do is look at IBD the future. And whereas Kim is probably like a decade or so younger than I am, when I started fellowship, there was prednisone and sulfasalazine. It was easy. It's not so easy. So I'm going to talk about IBD, the future. And I also limited myself to a couple of different topics because we actually really are making progress and we have, I think, what is a bright future. And what I'd like to really go through is I'd like to talk a little bit about the concept of precision medicine. I'd like to talk about some of our new therapeutics. Kim touched on those a little bit, and then positioning of therapy. So starting with a case, this is a typical case coming into clinic at UNC, 28-year-old male, moderate to severe ileocolitis since age 12, early surgery with a rapid post-op recurrence. He responded to methotrexate, which the pediatricians tended to use a lot in that population. Then he flared, infliximab was added, he responded for 4 years. He then lost response, was switched to adalimumab with some response, then had increased disease activity. He comes now with significant abdominal pain, tenderness on exam, a CRP of 99, anemic, his albumin is 2.4, 8 to 10 bloody bowel movements per day. His past medical history is significant for retinal detachment. He's blind in one eye. So what are we going to do with him? How do we know how to treat him? How are we going to fit these patients in any kind of paradigm with all of the options that we have? So I'd like to start off by looking at precision medicine, and we'll come back to the case. Precision medicine has really been used extensively in oncology, and it is a medical model in which there is customization of healthcare, both medical decisions, therapeutics, management, and they're directed towards a subgroup of patients instead of one drug fits all. So when I started, it was just steroids, one drug fit all, because that's all we had. Now we have more. So what do we have right now in terms of IBD and precision medicine? Well, the PANTS study, which was personalizing anti-TNF therapy in Crohn's disease, was a genome-wide association study in 1,240 bio-naive patients who were starting infliximab or adalimumab. They took a variety of different disease aspects of serologic markers, and the patients were followed to look for the time of development of anti-drug antibodies. And antibodies, they had to have a level of greater than 10 units per mil. And they found in this study that the HLA-DQA1605, which actually comes at our place as part of the celiac panel, was associated with immunogenicity in this patient. So if you look at this graph, the blue lines are patients that do not carry this, this haplotype. And if you look over time, the blue lines are above most of the red lines. And so as you go out, that is the percentage of the top at a year, 92% of patients with infliximab monotherapy. So the dotted lines are monotherapy. The red line carried the copy. So 92% of the people that carried this marker and that were on monotherapy developed antibodies to anti-TNF therapy. Whereas the lowest rate of immunogenicity were those patients who did not carry any of these alleles and were on combination therapy. So combination therapy was working better than monotherapy, and those who did not have this allele did better in terms of immunogenicity. So we have that now, and that's something we'll talk about. We can test for that. So this may help us decide who should go on monotherapy and who should be on dual therapy. We've known about TMPT metabolism for a long time, and this classifies as precision medicine as well. Both TPMT activity or low TPMT activity or NUT15 polymorphisms lead to increased thioguanine, increased 6-TGN when treating a patient with thiopurines, and those patients that have increased 6-TGN lead to increased myelotoxicity. So patients that have those polymorphisms need to either be started at lower doses or alternative classes of medications than thiopurines should be thought about. And one needs to think about this with thiopurine combination therapy as well. Both of these tests are commercially available and need to take that into consideration. So again, we're adapting our population, our drug therapy based on these findings. So what don't we have commercially available that are things to look out for? Brazikumab is an anti-P19 antibody directed at IL-23, and we know that we've got ustekinumab right now, which blocks IL-12/23. So this is one of the IL-23 specific therapeutics that's in trial. And this targeted therapy has been shown to be effective in ulcerative colitis. IL-23 actually induces IL-22, which stimulates gut epithelial proliferation. And in the clinical trials, it was demonstrated that those patients that had very high IL-22 levels were the patients most likely to respond to this particular therapy. So again, this may be something that will tell us this patient is more likely to respond to even ustekinumab or the other more specific IL-23 mechanisms. So again, directed therapy, precision medicine. What else do we have? Oncostatin M. It's part of the IL-6 cytokine family. It's increased in inflamed intestinal tissue from patients with IBD. Both serum and tissue levels are elevated in newly diagnosed patients, and elevated colonic levels predict an early need for biologic therapy. So somebody who has elevated Oncostatin M may be somebody that we're not going to wait for some of our milder therapies to work on. Elevated levels were also shown to be predictive of a primary non-response to anti-TNF and to vedolizumab. And I want to direct you to the graphs on the side that say prognosis, anti-TNF, and vedolizumab. And that shows you the patients who had a poor prognosis had higher levels of the Oncostatin M. Those who responded to those who had higher levels of Oncostatin M did not respond very well to both anti-TNF and vedolizumab in this study. Now, we heard a very elegant discussion this morning about C. difficile and the microbiome. So the microbiome and the metabolome, those are products that these microbacteria are making. They are I think, going to be a good part of the future in IBD. So there were a couple of studies, and this is just one of them, that showed that the microbiome and metabolome may predict response to anti-TNFs and predict risk of relapse. And if you look at the graphs on the left showing histidine both in the feces and the serum and in the urine, those who were non-responders to anti-TNF had lower levels of these particular amino acids, which reflected a difference in the microbiome. So some of the pills that we heard about this morning that contain bacteria may help us change that microbiome and metabolome to then have patients either respond without the addition of an anti-TNF or with some of our biologics. There's also a study that I'm not going to show you that shows there are changes in the metabolome that predict early recurrence after surgery. We're not there yet because it's not easy to check these things, but these will be things likely in the next 10 years that will be commercially available. The most recent thing that I think is incredibly interesting, because we use a lot of antibiotics in our patients. This particular study looked at antibiotic exposure in patients prior to and during the initiation of anti-TNF. So the patient could have had antibiotics before, during the course of their disease, and patients that had been exposed in the past to cephalosporins or penicillins or beta-lactamase inhibitors had higher levels of anti-drug antibody levels, whereas those patients that received fluoroquinolones or macrolides, they actually had a reduced rate of immunogenicity. I don't know how to use this yet. In the same paper, they showed similar things in mice, but it gives you pause, because if we're using a lot of these other antibiotics, are we then changing the way that they're going to respond to our drug therapy? So I think something to look forward to in the future of IBD is what's happening with the microbiome, see how we can use it and how we can manipulate it. All right. So how do we use precision medicine? It may help us decide who needs combination therapy to prevent antibody formation, who's more likely to respond to a different class of medications, who's more likely to relapse after surgery. And if we know that, we can initiate therapy early postoperatively in that particular patient population. So hopefully, as we move forward, we can use our drugs more effectively, and it'll help us with those decision trees. So what about the new therapeutics? Kim went over a couple of these. The new kids on the block are the IL-23 specific antibodies. Many of them are close to being approved. Some of them are already approved for psoriasis. They're JAK selective agents, and then a little bit on lymphocyte trafficking, the S1P modulators. So what about the IL-3 specific antibodies? As I mentioned earlier, we already have ustekinumab. Ustekinumab shares is targeted against the P40 subunit, but both IL-23 and IL-12 have that P40 subunit, so it knocks down both of them. These IL-3 specific antibodies specifically bind to the P19 subunit and block only IL-23, and there may be some advantages to that. We have Mirikizumab, Risankizumab, Brazikumab, and Gozilkumab. Both Risankizumab and Gozilkumab are already on the market in the psoriasis framework. And so I'm just going to show you one graph just to show you the Mirikizumab data. This one is not yet on the market, but is completing phase 3 trials. And this shows you in phase 2 studies of moderate to severe Crohn's disease that there is a marked endoscopic response even at week 12 compared to placebo. In the UC trial, phase 2 UC trial, again, there is a significant difference in clinical remission and clinical response, both of these suggesting efficacy, and it'll be time to see how this compares to ustekinumab blocking both the 12 and the 23, but there does look like there's efficacy in both disease processes. We'll see what the safety concerns are going out as well. So JAK inhibitors, you heard about tofacitinib. And so what are JAKs? They're a family of receptor-associated kinases needed for downstream regulation of cytokine receptors. So we know that cytokine receptors are important in IBD, and inhibiting JAKs block many of the pro-inflammatory cytokines. But if you inhibit different JAKs, you have different effects. There are 3 JAKs, JAK 1 through 3, and TYK2. And the little diagram on the side shows you that they do many, many things, including have an effect on both immunity and also red blood cell production. So tofacitinib is a pan-JAK inhibitor. It inhibits JAK3 and JAK1 and to a lesser extent JAK2. It is effective in the induction and maintenance of remission in ulcerative colitis. There's a lack of efficacy in Crohn's disease. And the issues were outlined by Dr. Pursley. You need to fail an anti-TNF prior to use, and this in part has to do with some of the safety concerns regarding DVTs and PEs at the 10 milligram BID dosing in the rheumatoid arthritis trials. There's an increased risk of herpes zoster. And so there are concerns, but it is a fairly effective drug and it does work fast. What are we looking at in future directions with tofacitinib? Well, combination therapy, induction regimens in acute severe ulcerative colitis. There's some case data out there that suggests that tofa works very fast and might be able to be used in the hospitalized severe acute ulcerative colitis patient. And also, what do we do with dose reduction in stable patients? So what's coming in terms of JAK inhibitors, increased selectivity, which may be increasingly efficacious and decreased toxicity. And the 2 that are in trial are for IBD are filgotinib and upadacitinib. And the upadacitinib looks very, very promising. And you'll see that whereas tofa hits all the JAKs, the filgotinib and the upadacitinib do not. They're much more selective. So this is the phase 3 trial from a recent press release, and it's really quite dramatic. Clinical remission, and this is at week 52, so this was a maintenance study, was in over 50%. There was endoscopic improvement. There was HEMI is, I guess, a new term, histologic and endoscopic improvement, and then corticosteroid-free remission rate. So this is actually very exciting. We'll have to see how this fits, whether this will even take over from tofacitinib, especially if the safety concerns are there. Now, what about JAK inhibition in Crohn's disease? We know that the tofacitinib didn't work very well for Crohn's disease, but both filgotinib and upadacitinib patients show some promise in Crohn's disease as well, both in clinical remission, clinical response, and endoscopic remission. So we'll have to see where these go, but something to keep out for in terms of future directions. The bad thing is, as of September 1st, the FDA put a black box warning on tofacitinib and also on baricitinib and upadacitinib, which are already on the market, and they went further beyond the clotting issues. They noted that there was increased risk of serious cardiovascular events, both heart attack and stroke, increased cancer, lung cancer, lymphoma, blood clots, and death. Much of this was in the rheumatoid arthritis population, taking all the trials, and they've limited the approval of these JAK inhibitors to patients who have not responded well to TNF blockers, and that includes the RA, the psoriasis population. The FDA included in this both the baricitinib and the upadacitinib in the warning because of the class of drug, but it's very limited data, and we don't really know what the selectivity is going to do. And then finally, the S1P1 modulators. So we heard a little bit about this with ozanimod. It's the first one that it's improved in class. And activation of lymphocytes is important in the immune response. And it occurs in secondary lymphoid organs, spleen, lymph nodes. And the S1P actually guides circulation through the lymphoid organs in a gradient-dependent fashion. So these modulators actually block the egress of lymphocytes from the lymph node. So if you looked at a patient's lymphocyte count on these drugs, it's going to markedly drop because these lymphocytes are being trapped in the lymph node so that they can't do their damage elsewhere. This just shows you the ozanimod induction trial in UC at week 10. And I want to point out the big difference is in terms of prior TNF exposure. Those who had no prior anti-TNF exposure did much better than those with prior anti-TNF exposure with ozanimod. So that needs to factor into where we use this. So if you have a patient, you can't really use this as a last resort. If you've already done anti-TNF, it's not going to be as effective. And again, that comes back to our first biologic is usually going to work the best, and we have less efficacy as we go on. So what the label, Dr. Persley also brought this up. A lot of the information on the label is due to the trials, how the trials were run, and a lot of the way the trials were run were based on the parent issues with the parent drug in MS, the fingolimod. But you need to do a CBC with lymphocyte count, LFTs, an EKG. You want to rule out a long QT. You need to do an eye exam if there's prior issues with uveitis or macular edema. You need to wash out prior immunosuppressant drugs. You need to wash out drugs that are associated with AAV conduction problems. You need to test patients and immunize them for varicella zoster. Other considerations, you want to avoid people that have had a variety of cardiovascular events. You need to slowly titrate the drug up over a 7-day period. And you don't want to start during an infection and consider stopping for severe infection. So there are a number of things, and we don't know how this is going to translate into practice for ozanimod, but things to take into consideration. So I'm going to finish up with just a couple of slides. So the concepts in positioning therapy, I think that going to many of the guidelines is very helpful. You want to look at both efficacy and safety. Positioning therapy is individualized based on their prior therapy, patient comorbidities, age, extraintestinal manifestations. Again, I can't say this enough. First therapy in terms of biologics usually has the greatest efficacy. So you want to choose what is going to work the best in your situation. Unfortunately, positioning therapy may be affected by insurance. In North Carolina, we're having a lot of insurance denials on people that have been on medications for years for their ulcerative colitis. Decision support tools are very helpful. It uses the clinical trial data. There are very few head-to-head trials. Dr. Persley went over both of them, the Varsity and the Seaview trial. We need more of these head-to-head trials so we can figure out what populations it works the best. Memorize this. No, don't memorize this. This is just to show you all of the UC induction trials. And the middle part, everything is pretty similar. This shows you the efficacy and the delta from placebo. The ones that really stand out here are the Infliximab trials and the Upadacitinib trials in terms of both their delta and their efficacy. Recognize these trials are all done a little bit differently, so these are not head-to-head comparisons. And then this is a similar trial for Crohn's disease induction trials. So we don't have 90%, 100% response in these induction trials. So knowing which drug to use, what's going to work the best in a patient is what is important. So if we go back to our case, he's a 28-year-old male. So he's had moderate to severe Crohn's disease. He's already had a surgery. So he's a young age, high risk. Would stool analysis have helped us predict an early recurrence? Should he have been put on medicine right away? He's responded to methotrexate, but then he flared, and infliximab was added. Would precision medicine, if we had known his HLA type, would we have known he had antibodies and used combo therapy up front? He lost response. He's treated with adalimumab with some response, then increased activity. We need a new mechanism of action. We need to position therapy. We might need to use dual therapy. He's now presenting with significant abdominal pain and clearly worsened disease activity. Is there anything else that we can use right now to help us decide on therapy at this point? And that's where precision medicine is going to hopefully help guide us in the future. His past medical history, he's had an eye issue already. Now, this is not UC, and so we're not going to use ozanimod, but we want to probably avoid that class because he already has eye problems. So you can see that what we have to look forward to in the future for both IBD therapy, positioning therapy may very well depend on our mechanisms of actions, our new mechanisms of actions, and precision medicine in IBD. And I want to thank you, and thank you for having me.
Thank you very much, Dr. Persley and Dr. Isaacs, for an excellent presentation on the current and the future state of IBD. Now, in this session of Luminal GI, we are going to move into lower GI disorders. So the next presenter is Dr. Summer Harris. She's a staff gastroenterologist at Texas Health Resources, Dallas, and I have known Summer over a decade as a fellow at UT Southwestern Medical Center, then as a colleague when she was assistant professor there, and then she transitioned to private practice in 2019. Her passion is in GI dysmotility, and especially in POTS and gastroparesis. And today she's going to talk about the disorders affecting the pelvic floor.
Good afternoon. Thank you, Rupa, for that kind introduction. And thank you for giving me this interesting topic to talk about. So this is a topic close to my heart. I know as gastroenterologists, we tend to shy away from asking patients these questions. So moving on. So I'm going to spend the next 20 minutes talking about the basic neuroanatomy and physiology of the pelvic floor, and then moving on to the specific topics. So the pelvic floor, the topic itself, I think the word itself is very enigmatic and complex. It consists of both fascia and muscles. There is a division into the anterior, middle, and posterior compartments, and as gastroenterologist, my interest is mainly in the posterior compartment. The three muscles that I'm most interested in is the internal anal sphincter, the external anal sphincter, and the sling of the puborectalis, which is part of the levator ani. So how do we all defecate? It's an active process, like I explained to my patients. We maintain continence at rest basically because of the inherent tone of the internal anal sphincter, which is under sympathetic control, as it is a continuation of the smooth muscle of the rectum. When you want to squeeze, you have contraction of the internal, external sphincters and the puborectalis. The anorectal angle is formed by the sling of the puborectalis as it loops around the junction of the anus and the rectum. At rest, it's about 70 degrees. As you get to a point when you want to have a bowel movement, the initiation of defecation is with contraction of the abdominal muscles and the diaphragm. The sling of the puborectalis relaxes, thus allowing the anorectal angle to straighten and become more obtuse. The process of defecation, with being active, the internal and anal sphincter relaxes and the rectum contracts and helps expel stool. We all see patients with constipation. In fact, 40% of the patients that we see with constipation have dysenergic defecation. Symptoms are great to assess colon transit, perhaps not too great for pelvic floor dysfunction. Yet studies have shown that the more common symptoms that patients mention are difficulty with straining, incomplete evacuation, and abdominal bloating. An affirmative response to a patient, if you ask them, how do you poop? Do you have to squeeze your anus or relax your anus? And if they reply that they have to squeeze, is about 80% sensitive for dysenergic defecation. Both patients with IBS diarrhea and IBS constipation are known to have abnormal anorectal manometry study showing dysenergia. The digital rectal exam, I think it's a point of contention. I remember as a fellow, I had an attending who always asked me, did you do a rectal exam? And not to check for FOBT, but really to see how the patient pooped. So it's underutilized in clinical practice, mainly because I don't think we train our residents and fellows to do it. But it's been found to be a reliable indicator of dysenergia. The positive predictive value is about 97%. This is mainly for dysenergia. The test isn't that great to assess for either sphincter defect or for incontinence. So explain to the patient why we're doing this. They're usually well covered, and I have all of my equipment set up. There are about 5 or 6 components that are critical. The inspection of the anus and the surrounding areas will help us determine if there's a gaping anus, which points to pudendal neuropathy, if there are external hemorrhoids, perianal excoriation, and so on. The anocutaneous reflex is elicited by stroking the perianal skin, and what is normally expected with an intact S2 nerve is a brisk reflex. Digital palpation involves placing a lubricated gloved finger into the rectum. The patient is asked to squeeze, and often by flexing the proximal interphalangeal joint, you can assess for levator ani syndrome, where the patient can have extreme pain. The resting sphincter can also be checked for defects, but that's not a great test. Next, when the patient is asked to squeeze, you would expect protrusion of the examining finger along with pelvic floor descent. Going on to testing, one of the first tests, or at least as a gastroenterologist, one of the first tests that I'm interested in when I have an abnormal digital rectal exam is anorectal manometry. It allows for comprehensive assessment of anorectal function. In addition, can also be useful for detecting sphincter defects. So we're currently in high definition manometry. So a probe, which is about 11 by 6 centimeters, is inserted into the rectum and has about 256 sensors to help us assess pressures. So in 2019, the International Anal Physiology Working Group brought out the London classification on a protocol. Thus, we have a more standardized approach to looking for dyssynergia. We get informed consent from the patient. An enema is taken the day before, and the patient presents for the exam, which is usually done by a nurse or a tech. So these are the maneuvers that we usually do as part of anorectal manometry. First, the probe is inserted, and there is a 3-minute resting period where we allow for any contractions or slow waves to pass before we measure the resting pressure. The high pressure zone is an accurate measurement for the length of the anal sphincter. After that, the patient is asked to squeeze. There are 3 short squeezes, which is 5 seconds each before we move on to a 30-second squeeze. The cough reflex helps assess for integrity of the S2 reflex arc and make sure we are not dealing with either UMN or lower motor neuron lesions. When the patient bears down, the rectal pressure should increase, the anal pressure should decrease, and that ratio is called a defecation index. Lastly, we also assess for a rectoanal inhibitory reflex. When the balloon that's inserted along with the probe is inflated, the internal anal sphincter should relax, and that's called a rare. So the rare is normally absent in the pediatric population in Hirschsprungs. In the adult population, if you've had an ileal pouch anal anastomosis or a lateral internal sphincterotomy, that can be absent. Rectal sensory testing is a key part of anorectal manometry, and that is achieved by sequential inflation of the balloon within the probe. Rectal hypersensitivity is often seen in patients with urge incontinence, IBS diarrhea, and hydrogen-predominant IBS. Rectal hyposensitivity, on the other hand, is seen in chronic idiopathic constipation. The reason why sensory testing is more important is if a patient cannot sense a balloon within the rectum, the patient can't be expected to actually defecate it out. So moving on to the balloon expulsion test, it's performed complementary with anorectal manometry test. The patient has a, cath. Can we go back one? Perfect, thanks. So the patient has a catheter inserted into the rectum, which is filled with 50 cc's. The patient sits on a bedside commode, is given the time to expel out the balloon. Normally, it should be less than 1 minute at the time that the patient takes. The test is great, with a great positive predictive value. The sensitivity is low. Thus, a normal test with an abnormal anorectal manometry can still point to dyssynergic defecation. Moving on to more structural assessment of the rectum, X-ray defecography is a fluoroscopic study. It allows both real-time functional and dynamic testing to assess the morphology of the rectum and the anal canal. This test has been around since the 70s and basically involves patient having installation of barium gel in the rectum and is asked to sit on a stool and defecate out the barium paste. So if you can look in figure A, you see the acute angle of the anorectal junction with the puborectalis sling, and you can actually see the mechanisms of normal defecation on this slide. A newer kid on the block is MR defecography. So the advantages MR defecography has over X-ray defecography is better delineation of the different compartments. The different compartments include the anterior, which is the bladder. There is also better delineation of structural abnormalities like rectocele, rectal intussusception, along with some functional abnormalities which will not be as well appreciated on anorectal manometry. And these are the 3 compartments that are best visualized with MR defecography. So going on to some examples of what you would see or expect to see on an MR defecography report. A functional abnormality that we commonly see can be confirmed with anorectal manometry is dyssynergic defecation. There's paradoxical, in figure B on the upper part, there is paradoxical narrowing of the anorectal angle and abdominal wall protrusion. Spastic pelvic floor syndrome is involuntary and inappropriate contraction of the puborectalis. The patient often has a sensation of fullness and inability to evacuate. Descending perineum syndrome is one more characteristic functional abnormality that is seen in patients who are multiparous and those with hypermobility syndrome. Usually what happens is there is an inherent weakness of the endopelvic or rectovaginal fascia, and this causes pushing down and protrusion of the abdominal wall. The ongoing pressure causes pudental neuropathy, and this contributes to fecal incontinence. So this is one of my patients who is 75 and came in with a sense of blockage. So she had a normal X-ray deficography test, and when she went in for anorectal exam, you can see on that slide there's a protrusion of the rectal wall, which is also demonstrated on the MR deficography study. These patients are challenging because they often have to undergo biofeedback before surgical therapy. Going on to some structural abnormalities. While we're interested in rectoceles and rectal intussusception, there are middle compartment disorders of protrusion, like a sigmoidocele or enterocele, which can simulate the same symptoms as a rectocele. Once again, that's where MR deficography comes into place. And lastly, rectoceles and rectal intussusception. So a rectocele is an abnormal bulging of the rectal wall in the anticipated location beyond what is expected. Normally, with long-standing dyssynergia, anterior rectoceles are more apparent and posterior rectoceles are rare. Not all rectoceles need repair, and typically we talk about rectoceles more than 4 centimeters being referred for surgery. Rectal intussusception is usually an invagination of the mucosa within the rectum and can be either full thickness or mucosal, and surgical repair is based on the differentiation. Endoanal ultrasound is the last of the trifecta of tests used to evaluate for pelvic floor disorders. The probe is inserted into the anal canal, and measurements are taken both at the high, middle, and the lower level. And you can best assess internal and external anal sphincters. The test has 100% sensitivity in assessing for sphincter defects. Unfortunately, the jury's still out on thinning, because as patient ages, studies have shown that external anal sphincter thickness decreases while internal anal sphincter thickness increases. The thinning of the perineal body can be measured pretty well using an endoanal ultrasound. So which test do I order? I think as a gastroenterologist, I'm biased to say that I would start with an anorectal manometry study. Again, there's a lack of normative data with only 1 or 2 studies looking at high definition manometry parameters. My next test would be the balloon expulsion test, which is done in conjunction with anorectal manometry. If my exam was normal and there was no concern for prolapse, the patient would undergo biofeedback therapy, and if there's no improvement, the next step would be an X-ray or an MR deficography. So going on to dyssynergic defecation. So we've all seen patients in our clinic who, are on laxatives, they just don't get better. Seen in about 40% of patients with chronic constipation. This is an acquired behavioral disorder where there's an inability of the rectum and the anus to coordinate movement, and thus the patient is not able to evacuate completely. 2/3 of patients have been found to have a defective toileting habit going back to their childhood. However, there are patients who've had obstetric injuries and also back injuries who present later in life. Interestingly, you can have patients who complain of dyssynergic defecation and severe constipation, often not responding to laxatives, and whole gut emptying studies can be abnormal in about 2/3 of these patients. So that's something to be aware of. So there are 4 types of dyssynergic defecation, and this is based on measuring rectal and anal pressure gradients. There is an absence of or inability to generate enough propulsive force in type 1 and type 3, and there's an inability to relax the external anal sphincter appropriately for defecation. Studies using subtypes of dyssynergic defecation and biofeedback therapy response have found that type 4 is probably the most difficult to improve their defecatory dysfunction. So the best therapy that we have for dyssynergic defecation is biofeedback. So we've had about 7 studies, and a meta-analysis looking at it has found that the odds ratio shows a 6-fold increase in improvement with biofeedback. Biofeedback is typically administered by a pelvic floor physical therapist. there isn't a strict protocol in terms of EMG catheters or balloons. There are usually 3 phases, one of which is the initial education phase, and phase 2 is the active phase, where the patient has a session once or twice a week for about 6 to 8 weeks, and then lastly, there's an enforcement phase. So biofeedback has been found to be superior both short-term and long-term, as well as more superior to sham biofeedback, pelvic floor exercises, and medical therapy. A recent study in 2019 showed that there was an efficacy that was equivalent between home biofeedback and more outpatient biofeedback. Right. Going on to fecal incontinence or accidental bowel leakage. So again, this is not a symptom patients want to volunteer. I usually hear patients say that I have diarrhea, and it takes a while for them to actually say they have incontinence. So it is defined simply as an inability to hold on to stool, when, or it is an involuntary passage of stool. So recent studies showed that 1 in 7 adult Americans have experienced fecal incontinence at some part of their life. The prevalence increases with age. It's higher in women as they get older, and the prevalence is can be up to 60%. The assessment of severity is based on fecal incontinence severity index and fecal incontinence quality of life. There are several subtypes which we use clinically to help move forward in terms of testing and management. Passive incontinence is when the patient is unaware that they have actually had leakage of stool, whether it's liquid, solid stool, or flatulence. And it suggests this is because of loss of perception of the rectum or an abnormality with the rectoanal reflexes. This usually does not exist with sphincter dysfunction. Urge incontinence is seen in patients which is related to sphincter dysfunction. And lastly, you have fecal seepage. Fecal seepage typically occurs in patients who've had a bowel movement, do not feel empty, and throughout the day may have a little bit of stool come out. Most of these patients have normal pudendal nerve functions tests. So the etiology and risk factors for fecal incontinence. So first, we're going to look at the anal sphincter. Anal sphincter injuries are most common in obstetric injuries. The most common one that we see are anterior injuries. And it's important to ask patients at their initial visit if they recall having any fecal incontinence after they had a vaginal delivery or if they had a forceps delivery. Other injuries that can be related include after hemorrhoidectomy or lateral internal sphincterotomy or fistulotomy. Non-traumatic injuries to the internal anal sphincter include scleroderma, where there's thinning of the smooth muscle. Neuropathy can cause it in patients, again, obstetric injuries, trauma, and stretch injuries, and type 2 diabetes. Anatomical disturbances of the rectum in patients who've had an ileal pouch anal anastomosis, rectal prolapse, or descending perineum syndrome, again, affects the capacity of the rectal wall to hold stool and empty it completely. Lastly, neurological disorders such as MS and Parkinson's, spinal cord lesions are also important. I always ask the patient, what is their baseline bowel habit? Do they have constipation with fecal incontinence, or do they have diarrhea with fecal incontinence? So ask them. I can't stress how important it is to ask patients that whether they have this or not. Ask about when this first started. Often a patient who's sustained an obstetric injury may not present with fecal incontinence till 40 years later when they may have developed pudendal neuropathy related to diabetes, or may they just have weakness of their pelvic floor. Their medications, caffeine, and food intake is also important. As a gastroenterologist, I always ask patients if they have urinary symptoms, such as increased frequency or anything consistent with interstitial cystitis, pelvic pain, dyspareunia, all point to more complex pelvic floor disorders. The diurnal variation of fecal incontinence is also important. Going back to exam, you start with a basic exam. You want to do a focused neurological exam, and once again, go back to the digital rectal exam where you're looking for anything concerning for prolapse. The basic testing for fecal incontinence goes back to what we just reviewed, which is anorectal manometry, endoanal ultrasound, and MR defecography. The first picture under anorectal manometry shows the resting pressure. This patient has pudendal neuropathy related to diabetes and had no resting pressure, but is able to mount a squeeze pressure. The endoanal ultrasound can help detect both internal and external sphincter tears. And lastly, MR defecography is to be ordered only if you suspect the patient has a prolapse. How do you manage fecal incontinence? So initially ask patients, when does it occur? What are their baseline stool habits? Do they have more diarrhea? Do they have more constipation? What are their triggers? Does it occur with heavy lifting? Does it occur with coughing? Ask them, do they have a time of the day when they actually have a bowel movement, and do they use fiber? Yes, we always use fiber. There's more evidence in using fiber for fecal incontinence than constipation. I recommend starting with a soluble fiber, typically about 2 grams, and then can go up as tolerated as long as they're aware of bloating. Incontinence-associated dermatitis can be awful, and I always tell patients when this happens, make sure, depending on if you have a tear in your skin or not, you can use a petroleum-based gel or a zinc barrier till it heals up. Patients are okay wearing diapers when they're mobile, but overnight I recommend using incontinence pads to prevent any continued, to make sure there's no continued moisture at these areas. The drugs for constipation and fecal incontinence. So we talked about fiber being the first medication we start with. Saline laxatives are excellent. I use usually magnesium citrate. Non-absorbable sugars like lactulose can be used, but they have the risk factor of having a lot of bloating, so I'd be careful. Enemas are often used in patients with fecal seepage. So having a toileting schedule and making sure the patient can use an enema perhaps 30 minutes after a meal would facilitate the gastrocolic reflex as well. Dulcolac suppositories are stimulants and can often help in patients who have dysenergic defecation along with fecal incontinence. The more traditional laxatives such as Amitiza and Linzess can also be used. So what about patients who have diarrhea related with fecal incontinence? While we're working up the diarrhea, patients always want to be on something to make sure that they have some control over their lives. Loperamide or Imodium is my go-to because my patient with fecal incontinence is often in their 70s. I want to use something that doesn't cross the blood-brain barrier as much. We start at 2 milligrams and I have them titrate up to 4 times a day. Lomotil is second line if loperamide is not efficacious. I'm really ask them to keep a close eye on anticholinergic side effects, and I would probably like to use fiber along with loperamide before I go to Lomotil. Amitriptyline has been shown to improve rectal urgency and also rectal hypersensitivity, and thus we start at a low dose of 10 milligram and can titrate up to 50 milligrams. The other medications are more for bile acid diarrhea and IBS diarrhea. Clonidine is an alpha blocker. It has both alpha agonist and antagonist properties and work great for patients with autonomic diarrhea related to diabetes. Again, I watch patients really carefully because of the effects on their blood pressure. And lastly, tincture of opium for patients who have just severe refractory diarrhea. What about biofeedback for fecal incontinence? I think there is a role for biofeedback in fecal incontinence. This is really more for patients who have weak sphincters or impaired rectal sensation, because biofeedback works to improve rectal sensory training. Patients with large sphincter defects and those with neurological disorders are not good candidates. Biofeedback requires a lot of motivation from the patient. And that's something that just cannot be done if all those faculties are not present. The different components include improving the strength and isolation of the pelvic floor muscles, along with a delineation of improvement in the rectal sensory training. So if a patient has failed biofeedback and the patient has not improved with medical therapies, we move on to invasive therapies for fecal incontinence. The choice is often dependent on if there's a neuropathy or there's a sphincter defect. Perianal bulking agents have been around since the 1980s. In 2011, Celesta came out and the results were pretty promising. So this basically involves an intersphincteric injection of dextranum or microspheres, which are stabilized in hyaluronic acid. The patient undergoes an injection, and this little bleb that's formed between the two sphincters becomes a fibrous mold and helps patients with passive fecal incontinence. The studies were promising. The initial studies showed 62% improvement at 24 months. So it was higher, about 52% at 6 months, and it persisted for about 2 years. A follow-up study looking at these patients found that the number had dropped to about 40%. Sacral nerve stimulation is probably the first-line surgical therapy for fecal incontinence. The advantages are that it is completely reversible and minimally invasive. The ideal candidates are those who have neurogenic incontinence and those even with small sphincter tears or idiopathic fecal incontinence. The patient initially undergoes a trial period where there's electrodes inserted percutaneously through the S3 foramina, and there's an external generator. The number of episodes of fecal incontinence is monitored for 2 weeks, and a 50% decrease in the number of episodes means the patient's a great candidate for permanent implantation. The studies have been really promising. One study called the Wexner study, which is a multi-center study with 120 patients, showed that 40% of patients had 100% improvement in weekly incontinence, and this persisted at 36 months. Just a few of the other options that are available or have been studied but are not much in practice is radiofrequency energy. So I would say this is akin to the Stretta procedure in the esophagus, where you use radiofrequency energy mainly to treat patients who have moderate fecal incontinence with anal sphincter dysfunction. There is scarring of the anal canal along with collagen formation, and this allows for more improved sphincter function by creating more of a barrier. The studies have only been done in young patients with shorter duration of fecal incontinence, so we need more data before recommending this. Lastly, patients who have failed sacral nerve stimulators and are not candidates for SICA, we talk about artificial bowel sphincter. The one that has marketed and FDA approved in the US is Action Neo Sphincter. So it has 3 parts. It has a cuff that's placed around the anal canal. There is another pump, and there is a pump which is then placed within control of the patient. So the patient is able to deflate the cuff and thus allow the patient to have a bowel movement when there is an urge. Again, small studies with a high failure rate, so not used as much as we'd like it to be used. Magnetic anal sphincter, or Phoenix, is the lower GI tract equivalent of Lynx. It comprises of a ring of titanium beads, which has interlocking magnets and is placed laparoscopically around the external anal sphincter. The FDA approval was obtained based on one small study of 35 patients in 2011. There was a follow-up study looking at these patients, and they found of the 35 patients, about 7 of them had to have explantations related to complications. So again, not great. Finally, moving on to surgeries for fecal incontinence, overlapping sphincteroplasty is the one that's reserved for women over 40 postpartum with traumatic fecal incontinence. Long-term data isn't very promising. Dynamic gracilloplasty involves placing the gracilis muscle from the thigh and creating a neosphincter, which is then has electrodes implanted with an external generator. Lastly, the patient's miserable. We haven't had anything that works. We can refer a patient for a colostomy. Most of these patients, by the time they say they want a colostomy, they have tried everything and they're ready to have a better quality of life. I just mentioned MACE. It's called a Milan antegrade continence enema. This involves placing a conduit where the appendix is surgically reinserted into the cecum. And the patient can have 1 liter of normal saline used as an enema to really empty out the colon. I've inherited patients who've had this placed as children, but I've not had any adult patients who've had this. Right. So to summarize, we see a lot of these conditions in our practice. I think it's a matter of often eliciting the history, doing an exam. Dyssynergic defecation is more common than we find, and it responds beautifully to biofeedback with 70% rates of improvement. Fecal incontinence has pathophysiologic mechanism of both sphincter tears as well as neuropathy, and there are ways we can improve their quality of life. All right, thank you.
Thank you very much, Summer, for that comprehensive overview. Our next speaker is Dr. Waqar Qureshi. He's a professor of gastroenterology, clinical director, and chief of endoscopy at Baylor College of Medicine. And he's going to talk about in-office management of anorectal disorders.
Hello, good evening. Privilege and an honor to be invited to talk at probably one of the best clinical courses in this country. So anorectal disease has lagged in training behind the rest of what we are taught in fellowships. And as a result, a lot of us leave stuff to the surgeons, lots of business. And you know, my fellows now know that hemorrhoids are not something you just sit on, right? You get to know the basics, and then you can stand behind your work, if you like. Okay, you don't have to wear PPE to fix hemorrhoids. Okay, this is a very misleading slide. How common is anorectal disease? Well, very common. And the most frequent diagnoses are hemorrhoids, anal fissures, and pruritus, all of which we can fix ourselves. These are not surgical referrals. Abscesses and fistulae are. So about 50% of 50-year-olds in this country have symptomatic hemorrhoids. That's a lot of business. You know, that's 5% prevalence. We're sending a lot of these patients. So I did my own research, as people do these days, and went looking at a random group of gastroenterologists. I found that nobody was over the age of 50, so I had to move on. You know, we spend $250 million annually on over-the-counter products. The most commonly shoplifted item in a pharmacy is Preparation H. So think of that. That $250 million is even higher. We have more than 120,000 hemorrhoidectomies done per year. I can assure you some of those are unnecessary and just contribute to the surgeon's RVUs. So what are hemorrhoids? They are large vascular cushions in the anal canal. The hemorrhoid complex is connective tissue and AV communications. They're all fairly consistent in their position. You have your left lateral, your right anterior, and your right posterior. Etiologies, straining, whatever you're doing. When you're straining, chronic cough, heavy lifting will predispose you to hemorrhoids, as will chronic constipation. Prolonged lavatory sitting. Now, you know, the smartphones have really given us something to think about. And this is what I found very useful. Don't take your smartphone into the toilet. It adds RVUs to me, but I would advise you not to. Now, the other things associated with hemorrhoids are pregnancy, ascites, liver cirrhosis, and family history. Pregnant women get hemorrhoids, and my advice to you is be very polite, give them an ointment, and tell them to come back after their pregnancy. Because for those of you that know that I did a residency in OB-GYN before I moved, well, not very far, I stayed in the vicinity. But pregnancy causes hemorrhoids to worsen, so don't treat them for at least 6 weeks after pregnancy. Classification is really easy. You know, you have your dentate line. I don't know if I have a pointer, maybe not, okay. You have your dentate line, you can see there. Anything above the dentate line, internal hemorrhoids. Anything below, external hemorrhoids. External hemorrhoids are covered with anoderm, very sensitive. Do not band or cut or heat an external hemorrhoid. But internal hemorrhoids, as long as you know what you're doing, you can do what you want. The other classification relies on the amount of prolapse. So people who just see blood on their toilet paper, first-degree hemorrhoids. People who say, when I wipe, there's a bulge, it just goes back when I stand up. That's second degree. Third degree, they have to push the protrusion back in. And fourth degree is when they cannot. So the first three of those are amenable to office treatment. Now, I'm not going to go through this because we have, my previous speaker did a great job, but that's just the most important part of the human body. I thought I'd just show there quickly. Anoscopy, you must learn anoscopy. Anyone worth his salt has an anoscope in his pocket. And I'll tell you why. It's the only way you look at the anal canal. A scope does not let you look at the anal canal. If you miss small cancers, guess what? It's your fault. And the way to evaluate hemorrhoids is with an anoscope and not with your colonoscope. So there you can see the patient lying on their left side, sacrum to the left, and you have the right posterior, right anterior, and left lateral hemorrhoids, right? If this was a scope during colonoscopy, you could squirt fluid in there, and it will level on the left side because they're lying on their left, and you'll know which the left lateral is to accommodate yourself. And also, hemorrhoids don't hurt. So if your patient's in pain, it ain't hemorrhoids. This is a real-life picture of a posterior, right posterior hemorrhoid through an anoscope. And as you rotate the anoscope, you'll see the right anterior and the left lateral. And then as you slowly take the anoscope out, you'll see the anal canal and then the dentate line and then the skin. And just to drive the point home, we sometimes wonder why patients are uncomfortable after banding. Anything inside that red line is external hemorrhoids. So if you band, or you band so close to that red line that it pulls the red line in, your patient is not going to be amused. Now, very often we do colonoscopies, it's a dark room, and we can miss stuff. Look at this, colon cancer, anal cancer. You need to look carefully with your scope light before you decide that everything is fine. Perianal exam we heard about, very important. I'll just show you a few pictures just because you've had lunch and you're getting settled. This is, the center one is a prolapsed internal hemorrhoid, and you see external hemorrhoids around it. So you definitely wouldn't touch the external hemorrhoids there. Here, I would ask you to wear gloves. This is condyloma. The surgeons are well equipped to handle these. When they use cautery on them, the virus aerosolizes, and not something you should go with. Chronically thrombosed external hemorrhoids, these over time become skin tags. They settle down and they go away. But sometimes, especially ladies don't want that there. And then you send them for a removal, which is not a hemorrhoidectomy. This is just a cosmetic deal. This obviously is rectal prolapse, right? It's not, it's colon mucosa. And this is a surgical case. This is acute prolapse, cannot be reduced, patient's uncomfortable. There's no way to deal with that except your friendly surgeon. So what are the non-operative treatment options? Hemorrhoid treatment is extremely easy, and it pays more than an EGD, and it takes about 10 minutes. So that should get you guys thinking. Hemorrhoid, rubber band ligation, IRC, infrared coagulation, I'll talk to you about, and bipolar diathermy are in vogue. Injection sclerotherapy and cryotherapy have gone out of fashion. Oops, sorry, wrong way. So rubber band ligation relies on the tight encirclement of the hemorrhoid complex above the dentate line. It's painless, for me anyway. No, sorry, it is painless. If it's performed correctly, it is painless. There are lots of devices on the market. They all do the same thing. They pull the mucosa into a device and release a band over. Most of them are done blindly. There are one or two that you can see through and see what you're doing. But honestly, technique is everything. This is an example of one being used, and you see the internal hemorrhoids being sucked into the device. And then the green arrow is the upper tube, the outer tube that pushes the band over the hemorrhoid. And what do you do? And here again, there's your dentate line, and there is where your band is going to be. It's not going to be near the dentate line, even if it's proximal, because you will pull the dentate line in, and you'll wonder why the patient is whining. This is what happens. If you put your band on, there's rapid ischemia on the right, and then it sloughs off. That does two things. It creates an ulcer where that band was, and the ulcer heals with fibrosis, so blood cannot come down into the hemorrhoid, and the fibrosis tacks the mucosa to the side of the rectum so that you don't get prolapse. So what you're doing is really creating a ring of fibrosis. And the results are amazing. You have people with prolapsing hemorrhoids who you can reduce, and you think these guys are going to surgery, and they can't believe that you fixed them. So what about pain after ligation? Well, the complications, some people report discomfort in 5 to 10%, and this is usually managed over-the-counter analgesics. Abscesses, urinary retention, and band slippage can happen. The complication that we fear is necrotizing pelvic sepsis, which is extremely rare, but it can be lethal. So all our patients get a handout that says, if you get fever, chills, rigors, pain, you come straight back to the emergency room, and they have a phone number for us. Okay, very important. But touch wood, it hasn't happened yet, and we've been doing, hemorrhoid clinics have been going for about 10, 15 years. Okay, you've just applied a band and the patient complains of 6/10 pain. Well, it's easy. You either band it below the dentate line, in which case take it off and band again, or you have more than just the mucosa in your band. And this is what happens when you have the muscularis caught in the band. So if you massage that hemorrhoid a little bit, is the only time massage pays in gastroenterology. Now it feels like a polyp on a stalk. Before it felt like a sessile polyp. It wouldn't move. And so always do a rectal exam afterwards and make sure your hemorrhoid tissue is freely mobile. Infrared coagulation involves heat, and I will show you how this works. This is the machine. On the left, there's a bulb inside that black dome, and when you pull the trigger, the right steel bit gets extremely hot and is covered with a disposable sort of condom-like thing. And you apply that under direct vision to the base of the hemorrhoid, and it blanches, and you know it's working. So I'll show you so it's under direct vision. You have to be in contact with hemorrhoidal tissue, and you apply it in about 4 or 5 or 6 areas where the feeding vessels are coming into the hemorrhoid, and the hemorrhoid will shrink. It's not as good as banding, but it works for pregnant women and patients who cannot come off their, anticoagulation. So because the band falls off in a few days later and they're back on the anticoagulation, so there's a small risk of bleeding. Okay, what about patients that have acute sudden onset of pain? That is the thrombosed external hemorrhoid. You will see these, and if you know how to deal with them, your patient will think you walk on water. And these people you can tell when they walk into clinic, they're walking funny, they're in a lot of pain, and they want something done. So external thrombosed hemorrhoids are associated with heavy lifting, straining, sitting, diarrhea, pregnancy too, and it's associated with increased anal sphincter spasm. And if they see you a week after their symptoms started, there's really nothing you can do. You treat them conservatively with lidocaine, nifedipine ointment, because of the spasm that they have, stool softeners, sitz baths, and they get better over time, 7 to 10 days. And once they present with a thrombosed hemorrhoid, they have hemorrhoid disease. So you're going to bring them back and band them after they've settled. But what if they present within the first 72 hours? That's where you can do your magic. This is a lady, 30 weeks pregnant, extremely tender, painful thrombosed external hemorrhoid. And she insisted I do something. And, oops. Can you click on that video for me, please? Thank you. So I'm cleaning this hemorrhoid with some iodine, and I'm going to anesthetize it with some lidocaine. And this is really the only painful part for the patient. They feel a little now, so I'm going to cut with a scalpel. Now, normally the clot pops straight out before you've even finished. But in this case, I think she'd gone over her 72 hours. That's not what she told me. But anyway, the thing is, at the end of the day, we delivered the clot. Oops, there it is. And, you know, you don't want that clot to form again. And that's exactly what will happen if you go home now. So you want to de-roof that thrombosed hemorrhoid so that it stays open, so that the clot is not going to form again. Okay? Surgeons like to pack these things, but honestly, you don't need to. Okay. So see, this can be done in 5 minutes in your clinic. So we have a hemorrhoid clinic where we, although these guys will turn up anytime, but you should have your kit, which is very easy to make. Okay, what about patients complaining of pain and you separate their buttocks and you see that? That's an anal fissure. Those things hurt like crazy when you stick your finger into the rectum. So it's diagnostic. The minute you do a rectal exam and they jump off the table, especially if you press posteriorly, that is an anal fissure. It's nothing else but an anal fissure. So quick diagnosis. Anal fissures are tears in the anoderm, usually caused by hard stool. In Houston, sometimes foreign objects. Chronic diarrhea, straining, sitting on the toilet too long, mostly found in the posterior midline because that's where the blood supply is the poorest. It is associated with a lot of spasm, which keeps the blood out and prevents healing of the fissure. But sharp pain on bowel movement is typical. You won't see every anal fissure, but the history is very helpful. And if you put your finger into the rectum and they have a high pain threshold, you will feel a defect where the tear is, a roughness in the lining. And you press on that and they will jump. So if you see tears other than in the anterior and posterior places, they probably have other disease, Crohn's, HIV, and so on. So it's a vicious cycle. Initiating trauma, you get pain and spasm, which causes ischemia, inability to heal, and it goes around, and you have to break that cycle. So the best way treatment, fiber, 15 to 20 milligrams a day. Ointments, the best ointment right now is a compounded ointment of nifedipine or diltiazem with lidocaine. That works great. The commonest problem is people use it, the pain goes away and they stop. You have to carry it on for 12 weeks and then they won't come back to you. Botox is expensive and I prefer to use it for other wrinkles, but you inject 10 units on either side of the tear and that is your final medical treatment. If they don't get better, they go to surgery. Okay, and my favorite there is the nifedipine and lidocaine, but there aren't a lot of studies in this area. What about this? We've been itching to get to this slide. You know, it looks terrible, and if they have good insurance, I want to scratch it for them. But this is just a list of things. Contact dermatitis from soap, perfumes, dye on the toilet paper, fungal infections common in alcoholics, citrus fruits, grapes, spices. And, you know, there's now this, what's that antioxidant Indian spice? Turmeric. People are using that from Costco's, very high doses, and they come, you know, scratching themselves. Laxatives, peppermint, some antibiotics cause itches. So what you do is you tell them to wear clean, dry, loose pants, cotton underwear. Balneol is great. It's $5 a bottle at Walmart. And you dab it on there 4 times a day, it will give you an outer relief. And if hemorrhoids are present or fissures, you treat them because they can cause oozing and a damp ecosystem there that causes the pruritus. So, summary. Perform a good anorectal examination. And my previous speaker gave a great how to do a digital rectal exam. That really picks up a lot more than you would imagine. And it's in-office treatment of hemorrhoids is safe, effective. Very few people need surgical intervention. You don't always see anal fissures. That's a clinical diagnosis. Hemorrhoids don't hurt unless they're acutely thrombosed. Look for other causes. Disorders of defecation can contribute to hemorrhoids and fissures. So if you if you have your finger into the anal canal, rectum, and you ask the patient to bear down and the puborectalis sling presses against you, they have rectal dysnergia. And as we heard, very high sensitivity. So know when to order anorectal manometry. And, I just, at the risk of personal promotion, I put these up, but they're also very good to put you to sleep if you're having any problem. I would ask you to have an anorectal clinic. And believe me, I think you'll find it very satisfying. It's not like a hard day at the orifice. Thank you very much.
I'd like to invite our speakers to come up for a quick Q&A session. And after the Q&A session, I'd like to encourage everybody to visit our exhibitors in the exhibit hall. Dr. Isaacs, Dr. Pursley, Dr. Harris will take any questions. Rupa, do you have some questions to start with?
I have 2 online questions.
Yep. There you go. You can sit right here.
So the first question is to Dr. Kim Isaacs. What would you do in a long-standing stable UC patient who came in with severe flare due to CMV? He has been treated for the CMV and now is tapering off prednisone. His only other medication is Lialda, 4.8 grams a day. He has pancolitis. Would you add a biologic now or assume he will return to his pre-CMV state and just use 5-ASA?
So I guess the first question that I would be asking is, why does he have CMV? Is he immunosuppressed in some way? And I would want to look for reasons why he should have CMV. Now, if he was already on high-dose steroids and he developed the CMV, he reactivated CMV because of the high-dose steroids, that's a reason for that. But a lot of times CMV and C. diff end up being also markers of severity with ulcerative colitis, with severe ulcerative colitis. So I would have concerns that that he's not going to do well just on a 5-aminosalicylate. So I would definitely treat the CMV. You're already on high-dose steroids, which are going to make it difficult to clear the CMV, but that sounds like somebody who's going to need sort of more aggressive therapy.
Let's take the live question there.
Yes, this IBD question. Can you comment on the data regarding probiotics and some of the supplement like turmeric on IBD patients?
Okay, so I'll comment on turmeric. There is actually one study on turmeric in ulcerative colitis that actually they compared sulfasalazine and curcumin, and they were equally efficacious. And I think that the dose was 3 grams a day, 1 gram TID for that. So there does seem to be a role. Sort of anecdotally, I've had a couple of patients who actually make tea out of turmeric and find that it's helpful. But the one study was done in ulcerative colitis. In terms of probiotics, and I'll be interested to hear what Kim has to say, there's not a lot of consistent data. The first information that we really had on probiotics was their role in pouchitis, and it's mainly Italian studies that showed that there might be a role of probiotics. We recently did some not exactly the same kind of study in pouchitis and didn't find any efficacy, but it's been very variable. I tell patients that if they feel like it makes them better, take the probiotic, make sure it doesn't have dust on it, and if it's supposed to be refrigerated, make sure they're getting it out of the refrigerator.
And what about curcumin?
Curcumin, I do have patients that are using the curcumin.
So the probiotic question comes up quite a bit, and patients are always curious to know what they can add to what they're doing, and it's something that's natural. I'm not a huge fan of the use of probiotics, and what I strongly try to encourage my patients to do is I actually try to get a fairly detailed diet history from them. And I encourage them that if they're eating kind of crummy, to kind of re-examine their diet. And the best way to promote a healthy microbiome is to increase the fruits and vegetables that they're getting in their diet. And I know this is somewhat, when we were in training, we would tell folks just eat whatever felt good, just eat it. But we do know that there is an impact on what they're eating and how it's going to promote a healthy microbiome, and also just try to limit the number of antibiotics that they may be exposed to.
So the second question is IBD. What is the role of azathioprine in young males and kind of older patients?
Role of azathioprine in young men and
young men and also the older patients.
Oh, and older patients. Sure. So, like I was saying earlier, the issue with, I think AZA and 6MP are good drugs. And I have a number of patients who are still on monotherapy. And some of my older patients, if they are starting to develop complications of being on long-term azathioprine or 6MP, we do talk about, taking them off of that drug. With the issue in young men, there was a concern about the role of combining AZA, 6MP with biologics and the increased risk of lymphoma in that population. So I do avoid using that combination of drugs in my younger male patients.
I have a question for Dr. Qureshi regarding to hemorrhoid banding. Do you ever do more than 3? And what if you do see some cushion that is not in the 3 usual location that protruding out? Do you aim at that location at a 4th banding or so forth?
Usually, if you have 3 well-placed bands, it doesn't matter necessarily whether you're on the band or not. You're producing enough fibrosis to go around. So occasionally a patient has had all 3 bands on. I do them 1 every 2 weeks for patient comfort levels and for the risk of infection. I don't band all 3 at once. I think that is quite unwise. You get enough fibrosis with the 3 that you don't have to be that specific. But if they come back after you've completed your treatment, then you do need to do another anoscopy and see if there is any redundant hemorrhoid vessels that you could target.
Dr. Qureshi, I have a question. Do you treat condylomas in the clinic, or would you send it to colorectal?
No, I send them to surgery.
Hello. My name is Ron Wool from San Antonio. This question is for Dr. Qureshi. Endoscopic band ligation of hemorrhoids. I was always taught in fellowship, and I don't think any of my partners endoscopically band. I know of a few in the community, but I was always taught you couldn't really control if you were within finger reach, if it was too tight, and just higher risk of deeper tissue layers.
Yeah, essentially they're doing the same thing, but a hemorrhoid bander costs $500. And you are being paid about $230 for your physician fee for banding. So if you're an ASC, you're losing money. We get away with it at hospitals sometimes, but this is an outpatient office procedure. You should not be banding during your colonoscopy. 1, unless you've had a specific request by the patient, you would not band all 3 hemorrhoids. And you can band them in a colonoscopy, but you're in a money-losing situation there. So you really need to do them in the office because they're equally effective.
A question for Dr. Harris? Can I ask?
Yes.
So quick question. A number of our patients with inflammatory bowel disease, fecal incontinence is a big problem, and particularly in those patients that have had prior surgery. Is there any data with how effective biofeedback can be in that group of patients?
Yeah, so there are about 2 small studies that have looked at patients who've actually had ileal pouch anal anastomosis and dysnergia. They found that they had actually they had rectal hyposensitivity, and they responded better to sensory training. So yes, I do see patients who've had surgery. And it's interesting to see that, sometimes even patients with ulcerative proctitis that is healed, develop, fecal urgency, and they respond to physical therapy as well.
All right, with that, we'll take a break and we'll start the next session here at 4:30. Thank you.